So today we'll talk about benign and malignant prostatic lesions, the pharmacotherapy of those lesions. So benign we'll talk about BPH, and then we'll briefly talk about prostatic cancer. So our learning objectives today are, from here. So we'll first revisit the anatomy of prostate and pathophysiology of BPH, which I think you have done it already with the pathology.
Yes.
You've done the pathophysiology, pathogenesis of BPH. So I don't need to go into those details. And then we'll correlate the pharmacological actions of different drugs that we use in BPH treatment. And those most common are alpha-1 adrenergic blockers. And there's some role of 5-alpha reductase inhibitors as well as phosphodiesterase 5-PDE5 inhibitors. And then there are some other drugs as well which may be used. And after we finish with BPH discussion, then we'll go to briefly discuss pharmacotherapy of prostate cancer. Okay. So starting with the anatomy of prostate, you know where is prostate located?
Yes.
Where is it?
Under the bladder.
Yeah, so it's inferior to the bladder and it surrounds the urethra. Huh? And that part of urethra we call it prostatic urethra. Is it in all human beings?
Male.
Only in males. Huh? Because in one of the hospitals there was a form for a patient who came in for the prostatic surgery, specially designed form for that patient, like for that kind of procedure. And one question was gender. So if you're preparing a form for prostatic problem, and then so that's why I was asking. So you know this on the left hand side you have normal anatomy, you have urinary bladder, and then there's a prostate sitting underneath it and surrounding the prostatic urethra. In BPH, what happens? Prostate gets bigger, there's hyperplasia, and that hyperplasia can lead to enlargement of the prostate, and because of that enlargement, there's obstruction to the urinary flow. The urethra is compressed. Number two, because as it gets bigger, it compresses on urinary bladder as well, and sitting directly underneath, so it compresses the neck region of the urinary bladder. So it produces irritation of the urinary bladder as well, the neck region. So again, it produces certain irritative symptoms as well. So there are obstructive symptoms as well as irritative symptoms. Mainly obstructive symptoms, okay? Because it's getting bigger, compressing the urinary bladder as well as urethra. So what are different, so again in urinary symptoms, you have upper urinary tract and your lower urinary tract. Symptoms are slightly different. In lower urinary tract symptoms, what are different symptoms?
Urgency, frequency.
Urgency, frequency.
Incomplete voiding of urine.
Okay.
Interruption of
Sorry?
Hesitancy.
Hesitancy.
interruption of urine flow.
Good.
Dribbling.
Dribbling, very good. So you describe different symptoms. Now can you categorize them into obstructive versus irritative symptoms?
Interruption of flow, obstructive, dribbling of urine.
Yes.
Because of obstructive.
Dysuria.
Dysuria is not obstructive symptom.
Irritation.
It's because of irritation. And that's more in UTI, not much not in BPH. But it's irritative symptom in LUTS. So we usually call them LUTS in hospitals. Lower urinary tract symptoms, LUTS. So you have obstructive symptoms, which includes hesitancy, like hesitation in initiating the urine. So difficulty in initiating the urine. And once they initiate, the urinary flow is very poor, weak stream. And then they have to strain a lot to pass the urine. Then that also prolongs the maturation process. So that takes longer. And obviously, they are not able to empty the full bladder. So there's always post-void residual volume left in the urinary bladder. And that gives them feeling of incomplete voiding. And then there's the urinary retention. They can go into urinary retention as well. That will that would be an acute presentation in the emergency. Also, as you said, dribbling, and dribbling can be post-void dribbling and as well as terminal dribbling. terminal, like at the end of the string, there's like in the end there like drops will be falling down. Post void is like after voiding after a little while, little bit urine again will come out. And as you said, intermittency, so like when they're passing, so again like they might stop at pass, so there's intermittency. So these are all obstructive symptoms. And then you have irritative symptoms, as you said, urgency. Urgency, you know what is urgency?
Yeah.
So they feel an urge to pass the urine and they have to rush to the washroom. It's coming out. And sometimes what happens, before they are able to pass it out, there is some leakage. So before they are able to sit on the commode seat, there is some leakage, so there is incontinence. So incontinence has different types. So the one that happens with this kind of urgency, we call that urge incontinence. So this is irritated symptom. When the neck of the bladder, the trigone area is being irritated, so there is urgency, urge incontinence, frequency is also that phenomenon of that thing. Dysuria is also irritated symptom, but that we don't see in BPH, so I haven't listed here, but if it is UTI, there will be dysuria as well. Okay? Or if it is prostatitis, there will be dysuria. And nocturia, because they are not able to void completely. So again, remember, frequency is different, polyuria is different, okay? Polyuria, oligouria are the two terms that you use for the total amount of urine that is passed, and you quantify it based on the 24-hour period. But frequency is like how many times they have to go to washroom. Each time they might pass a little bit of urine, but they have to go frequently, so this increased frequency. And the same thing, like when they feel this urge at night, so they have to wake up from sleep, so we call that nocturia. And what is causing these symptoms, as we just discussed, the prostate is growing with age, and there are other factors as well, and that puts pressure on urethra and restricts flow. Okay, so that produces all these symptoms. So, and you have done the pathophysiology of BPH.
Yes.
So you know what causes its growth. So what causes its growth?
Androgen.
And
DHT.
So yeah, so those are the main culprits. Is there anything else?
Environmental.
Environment. What sort of environment?
Smoking.
I think fatty diet.
Yeah.
I'm just listening to you. Like I'm not going because you have done it, so I don't want to influence that part. So you just stick to what you've learned. That's easy. I'm just asking you, and probably I might ask you some questions later. Like, what do you think? Just one question for like food for your thought whenever you're trying. You said androgens are the major culprit. Androgens are higher at a younger age or at older age? With aging, androgens go down or up? Down. Prostate size goes up or down with aging?
Up.
So, does it make sense? Maybe. Yeah, so this is what we're talking androgens. In males, androgens with aging, they go down. So I don't know, you think about that. But you stick with whatever you've learned. So because that's not my area of expertise, so I will not comment on it. It's just a question in my mind, so you can think about it whenever you have time. Not related to this block, okay? And then there may be a role of estrogens as well. So you can study about that whenever you have time. Again, not part of my pharmacology lecture, so you don't need to study that for this lecture. So treatment options, what do you think? What are different treatment options?
5-alpha reductase inhibitor.
So that's one thing, 5-alpha reductase inhibitor. What will that do?
Reduction of DHT.
It will reduce it. So it will reduce the size, huh? But will it be like, how long will it take? Any idea?
How long will it take for the action to occur?
Yeah, for the size to go down, that I have symptom relief. If the patient has symptom relief, 6 to 12 months. So, is there any other category of drugs that you want to put them on? Yeah, so alpha blockers, huh?
Alpha 1A.
But yeah, so you have alpha 1 blockers, very good. And then you have this yeah, so this category, there's a couple of other categories, but this is pharmacotherapy. Is there any other option besides pharmacotherapy?
Symptomatic maybe.
That's pharmacotherapy, like you give drugs, huh? But is there surgery, huh? So besides surgery and pharmacotherapy, is there something else that you can do?
Lifestyle.
Hmm?
You mean lifestyle changes?
Yes, lifestyle changes. So we have watchful waiting and lifestyle modifications, which again is not focus of my talk, but like again, like you can avoid caffeine, something which causes diuresis. You can avoid a lot of liquid before going to bed or before coming to the lecture. See, I'm also getting in that age. Huh? So these are this one of like, and then there are many other modifications, but they are more for the irritative symptoms rather than obstructive symptoms. We have pharmacotherapy, as you rightly said. We have alpha 1 adrenergic blockers. Again, keep in mind, in this lecture we'll be talking about alpha blockers. We are talking about alpha 1 blockers. Okay. There are alpha 2 receptors as well in the body. So we are not concerned with alpha 2 blockers here. Okay. Remember adrenergic alpha 2 blockers?
Yes.
So, and then in pharmacology, you must have studied in POD, there are non-selective alpha blockers and the selective alpha blockers. So at that time you studied non-selective, you meant non-selective for, that means both alpha 1 and alpha 2. One example is
Ephedrine.
phenoxybenzamine, no blockers, I'm talking blockers. Phenoxybenzamine, huh? That was the first drug which was used for BPH. But now we don't use that. So we are not talking about the alpha 2 blocker or like, so now we just are concerned with alpha 1 blockers. Huh? Otherwise, in the alpha blocking thing, in that learning, we use selective. That means we are talking about one alpha blocker type, like either alpha 1 or alpha 2. And when we say non-selective, we are talking about both. But in this BPH lecture and BPH treatment, we are just talking about alpha 1 blockers. And when we use the terms selective and non-selective, so there are subtypes of alpha 1 receptors.
Yes.
So we are talking about being selective for one of the subtype of alpha 1 blocker. So whenever there is term alpha 1 blocker, so that's like in BPH we will always talk about alpha 1 blocker. We don't use those alpha 2 non-selective these days. But here in alpha 1 blocker we have some subtypes, and then there are some which are selective for a subtype, others are not selective. We'll go over. Okay. So alpha 1 adrenergic antagonists. Then we have 5 alpha reductase inhibitors, as you said, like, and then there's some role of, and then obviously there's a combination of these two drugs. We will talk about like why we combine and what's the rationale of combination, and then we'll talk about phosphodiesterase 5 inhibitors, PDE5 inhibitors. There is like some role of them here as well, and then we'll talk about a little bit about anticholinergics and beta 3 adrenergic agonists. They help more with irritative symptoms. So they are not commonly used, but there is some role. Most commonly used is alpha 1 adrenergic blockers. That's your first line treatment for symptomatic relief. Then you can add some other drugs like alpha reductase or something else. And then obviously you have surgery. Okay. So let's just have a look at the distribution of alpha receptors in prostate and bladder. As you can see, the alpha 1 receptors are abundant in urinary bladder, especially in the trigone area, in the bladder neck, also in the prostate, at the internal sphincter. So if you, and what will, if, so alpha receptors are there, so alpha 1 receptors, so what will alpha 1 stimulation do? Any idea?
Contraction of the sphincter.
Contraction of the smooth muscles, huh?
Yes.
How?
The PLC calcium.
Hmm?
You mean
Yeah, so which G protein is coupled with alpha 1?
GQ.
GQ. So it's GQ, and when it gets stimulated, then what will happen?
It gets phospholipase C.
C, okay, and then?
It converts PIP2 to diacylglycerol.
So, yeah, IP3 and DAG, huh? And that will lead to more intracellular calcium. As when you have more calcium, it will lead to
Protein
contraction of the smooth muscles. So if it's in vasculature, there will be vascular contraction, constriction will increase the blood pressure, and if it is happening in the bladder neck, so it will constrict the bladder neck as sphincter, so it will obstruct the flow. So if you block those receptors, what will happen? There will be relaxation of the bladder smooth muscles and the bladder neck muscles, so, and also the prostatic smooth muscles, so it will relieve the obstruction. and because of that, urinary flow will be improved. So there will be symptomatic relief. The obstructive symptoms will be relieved. Okay. And what will happen in vasculature if you are using an alpha 1 blocker which also acts on vasculature?
Blood pressure.
Drop in blood pressure, hypotension. So it will lead to hypotension. And they are used in hypertension. Like one of the drugs used in hypertension are those alpha 1 blockers. Those which act on vasculature as well. So that's why we talk about subselectivity. There are drugs which act only on the renal tract, like they are uroselective. Then there are drugs which are non-selective. They act both on renal tract, like in the bladder, neck, and the prostate, as well as they act on vasculature. So they will have both effects. So subtypes of alpha 1 receptors, we have alpha 1A, alpha 1B, and alpha 1D. As you can see, alpha 1A is predominantly in prostate, bladder, neck. So this is the subtype of alpha 1 receptor which is predominantly there. So in urinary bladder, neck, and prostate, we have which type of receptor?
1A.
Yeah. So alpha 1A. Alpha 1B is in peripheral vasculature, and alpha 1D is like, it's not our focus today, but it's also present a little bit in bladder as well as liver and spleen. Okay. So then when we talk about alpha 1 blockers, so remember, so when we are talking about these drugs, these are alpha 1 blockers, not just alpha blockers. They are alpha 1 blockers. So and then we have two categories. We have non-subtype selective alpha 1 adrenergic blockers. So that means they will act on all 1A, 1B, and 1D. Okay, on alpha 1 receptors, which include trazodone and doxazone. Two names. So if you give these two drugs, what will happen? Hypotension, as well as you will have relief of the prostatic enlargement symptoms. So obstructive symptoms will be relieved, urinary symptoms will be relieved. At the same time, there will be hypotension. So you want to give this drug to a person who has hypertension as well. So if you have a patient who has BPH as well as hypertension, you can use one of these two drugs. Does that make sense?
Yes.
And suppose someone who doesn't have hypertension, so what will this drug do? So you are giving it for BPH. Usually, like these type of drugs, like alpha blockers, alpha 1 blockers, they produce they call first dose phenomena. So it produces orthostatic hypotension, especially with the first dose. It produces syncope. So you always start these drugs at bedtime. So because they are going to sleep anyways, so there will be less chance of orthostatic hypotension, and you start them at a very low dose, and then you gradually titrate it up when you're using trazodone or doxazone. Okay. And then you have subtype selective alpha 1A adrenergic receptor blockers. We also call them uroselective. So they are selective for alpha 1A. That's our concern. We are not much concerned about alpha 1A. Okay. So tamsulosin, silodosin, and effuzosin. So if you use these drugs, so will they relieve the urinary symptoms?
Yes.
Yes. Obstructive symptoms will be relieved. Will they affect blood pressure?
No.
No. So if somebody who has hypertension, you will not use this. This is not indicated for hypertension. For hypertension, we have trazodone and doxazone. So someone who has BPH as well as hypertension, you can choose one of those two. But if someone does not have hypertension, then you should prefer one of these three drugs, which are, can you name these three? Now, effuzosin, in vitro testing shows that it's not selective for the subtypes. Okay? But clinically, it produces effects similar to selective alpha 1 blockers, selective alpha 1A blockers, okay? Like tamsulosin or silodosin. So, like in clinical practice, it behaves more like a uroselective alpha 1 blocker. It doesn't affect blood pressure. So we put it in this category, okay? Is that much clear? So you have to memorize these 5 drugs, unfortunately for you. I'm sorry for that, drugs. So when we are discussing this lecture, we will try to answer these questions like how do alpha blockers improve the symptoms of BPH? What is the effect of alpha blockers on natural course and progression of the disease? What are the differential effects of alpha blockers, keeping in mind the selectivity and differential subtypes of alpha receptors? Which alpha blockers are most widely used in BPH? What do you think? Which ones should be used more?
Subtypes selective.
Yeah, so more selective for alpha 1A, like tamsulosin and alfuzosin and that. But if someone has blood hypertension, then we can use trazodone. And then we will talk about adverse effects. So alpha 1 adrenoceptor blockers, they improve urinary flow, they relax smooth muscles in the bladder, neck and prostate. They do not alter volume or prostatic volume or serum PSA, because they are not doing anything to the underlying pathology in the BPH. So they will not change the prostatic size, they will not change the PSA level. You know what is PSA?
Yes.
Okay. So they will not affect that pathology of BPH, they will just produce symptomatic relief, which is important. And this is mainstay of our therapy, but they will not alter the disease progression. They will affect the symptom progression, but they will not affect the disease progression.
Doctor, so can we say that they make the urinary incontinence worse?
No, the incontinence happens because of the urgency that comes in. So they will reduce the urgency as well. So they will not make incontinence worse. But if a patient has more like urgency and incontinence, if those symptoms are predominant, then we have another category of drugs as well that will help with that. They help more with obstructive symptoms, but as part of that, when the obstructive symptoms are relieved, when the obstruction is relieved, so bladder is emptied properly, like there is a full widening, like otherwise they are not able to wide it completely. So when there is full widening, so there is less irritation, and then there's like frequency goes down, so and the urgency should also go down. So when the urgency goes down, so then urge incontinence should also go down. Incontinence has different types. One is urge incontinence. So when urgency is reduced, urge incontinence should also reduce. Okay. Theoretically, you are right. Like if you're relaxing those sphincter muscles, then yeah, it can. But it's relieving obstructive symptoms. So the urine is going out. Like when they go, they have to pass it out. So then it should not produce those symptoms. So we don't have that kind of side effect with these drugs. And they will not alter the natural history of the disease. Okay, clear? So I'll just talk about blood pressure. So what are differential effects of alpha adrenergic antagonists? So if you're using trazodone or doxazosine, which are
No, sir.
Non-subtypes.
so they are non-subtype selective alpha 1 blockers. That means they will act on all subtypes, including alpha 1A, alpha 1B, and alpha 1D. Okay, which ones? Trazodone and doxazosine. So they are also indicated for treatment of hypertension. So if somebody has hypertension and BPH, then you can choose
No, sir.
which are.
Trazodone and doxazosine.
And if you're using them, again you have to start with a low dose and then you have to titrate the dose up. Okay, because of this cross-dose phenomenon. But these three, alfuzosin, tamsulosin, and silodosin, they are alpha 1A selective, or uroselective, alpha 1A selective. And among them, silodosin has the highest selectivity for alpha 1A, but others are also alpha 1A selective. So they are not indicated for the treatment of hypertension because they have no effect on vasculature. So they are not indicated for the treatment of hypertension, and therefore you don't need the initial dose titration because you don't have that first dose phenomena with them. They are not affecting the vasculature. Okay. So that should be your first choice of treatment when you want to start alpha 1 blocker, and if there's no blood pressure issue, then probably you want to start with them. Otherwise, you can go with the non-selective ones. Okay. Is that clear? Now let's talk about adverse effects. Again, as we just said, like orthostatic hypotension, and that's more pronounced with these two drugs. And then we have also dizziness, tiredness. Ejaculatory problems are more pronounced with the selective ones, like the siladocin and these. So they have more ejaculatory problems, including the retrograde ejaculation as well as anejaculation and rhinitis. And there's one more thing that can happen with these alpha-1 blockers, which is intraoperative floppy iris syndrome. This happens when somebody is on alpha-1 blockers and they are going in for cataract surgery. Then there, as a complication that can happen, you don't need to worry much about that. Okay, but there was a whole paragraph in up to date, so I just wrote the name. Most of these BPS slides are taken from Dr. Dileep's lecture from the last year. And then like I usually update them, so just so when I was reading on up to date, so I saw this fancy name, so it's put like that. Now let's come to 5-alpha reductase inhibitors, and we have two names: finasteride and dutasteride. Finasteride was the first drug that was discovered, and the second one they came up with, which is probably more potent, is dutasteride. So before we go into that, let's talk about the regulation of cell growth in BPH, which you already know. So you know testosterone gets converted to testosterone via 5-alpha reductase enzyme. No? This is depicted as a prostate cell. So in that prostate cell, so testosterone is being converted into 5-alpha reductase, and there are two isoenzymes or isoforms, so 5-alpha reductase 1 and 2. Two isoforms. Actually, in the body there are 3, but probably in prostate we have 2. And as you know, when DHT will, when it combines with its receptor, so then this whole complex will get translocated to the nucleus, and then it will act on some genes. It will affect the gene expression, and it will lead to expression of certain growth factors and cellular proliferation that probably you have done in pathology. But overall, it tips the balance in favor of more proliferation and growth of the prostate, and that leads to, as you said, androgens are responsible for this. So if we assume that androgens are responsible and they are the major culprits in this whole disease, so if you can somehow decrease the androgens, that should help like this process. So will that affect the disease progression?
Yes.
So this is the only category of drugs which will prevent or reduce the disease progression, which will reduce the prostate size, and hence it will produce the relief in the obstructive symptoms by reducing the prostate size. But obviously it will take time. So just few slides, descriptive slides. So as we said, it's multifactorial etiology. Androgens, particularly DHT, is responsible for the prostate growth, like it is important in its regulation, and binds to androgen receptors in the stromal and epithelial cells in the prostate. And then there is production of growth factors, which regulates cell division, proliferation, and growth of the prostate. DHT is about 5 times more potent than testosterone. It has 5 times more affinity for the receptors. And testosterone is converted to DHT via 5-alpha reductase, as we just discussed. We discussed these points, okay? So I'm just going through them quickly. And we have 2 isoenzymes or isoforms. In the body, we have 3. There's a third one now recently discovered, but in prostate, probably we have only 2. And both of them are found in prostate. And obviously, so hence we have like this conversion happening in the prostate, and that's why the size is increasing. This statement is important. Both isoenzymes of 5-alpha reductase are elevated in BPH. So in patients who have BPH, you see elevation of these isoenzymes. So this may be the underlying cause of. So it's not just the testosterone is going down or up with aging, but it's probably the upregulation of this enzyme, which is increasing DHT in the prostate, leading to proliferation.
What is the third type?
Third isoform? Where is it? I don't know. again, when I was reading for this thing, so it said there are 3 isoforms, 1, 2, and 3. So they did not specify where is it. So I assume that third one probably was discovered later. Initially, probably we knew about only these 2, but there is third one. That I'm sure. Which tissue? I don't know. So probably under the hair follicles.
Yeah, hair follicles, maybe.
Is it true?
No, maybe.
So I need to
I was
look
gonna
for.
say the same thing.
Yeah, I need to look for some specific inhibitor for that. If it's only under the hair follicles, huh? Because I was advised, I think when I was 4th year final year student, when it started, so they advised me low dose of 5-fluorouracil, and I said I can live with the hair loss. I won't use that because you never know about the side effects. But if there's some specific subtype under the hair follicle, and if we can, then we can try to look for some specific inhibitor for that. Okay, so what will be the role of inhibitors? As we just discussed, 5-alpha-reductase inhibitors, they will block the conversion of testosterone into dihydrotestosterone. So 5-alpha-reductase inhibitors will reduce the action of androgens on the prostate, and thereby they will shrink the prostate size, or they will reduce the prostate volume, in other words, because in prostate we talk about volume in ml, and therefore it will improve the symptoms and relieve the obstruction. Okay. So we see a greater benefit of this drug in patients who have much more enlargement. Again, patients who have BPH, the enlargement of the prostate can be different in different patients. Some patients may not have that big prostate, but they have symptoms of BPH. Others will have a very big prostate. So the greater the size of the prostate, there's more benefit of this category of the drug because it will affect the size of the prostate. So they are the only drugs which prevent or reduce the disease progression, and they also reduce the long-term need for surgery. Okay, is that clear?
Yes.
Okay, this is just to show you 2 isoenzymes, both in the prostate, they convert testosterone to DHT and they lead to enlargement of the prostate. So if you block them, so obviously DHT will be low and the prostate size will be low. So just for the mechanism of action, finasteride acts only on type 2 isoenzyme, while the dutasteride acts on both type 1 and type 2. So which one will be more efficacious? Dutasteride should be more efficacious in reducing the DHT level, and that's what was shown in one clinical study, that finasteride reduced the DHT 70%, while the dutasteride reduced it by 90%. So it was more efficacious in reducing the dihydrotestosterone levels. Okay, but clinically, when it comes to symptomatic relief, both are equally efficacious. Clinically, both have same response. This is a little bit strange, but so clinically, different trials have shown in terms of symptom relief, both are similar, and side effect profile is similar.
Maybe it's like the levels of isoform. Maybe there's more type 1.
Maybe. Probably the finasteride, only blockage of one isoform may be enough to produce the reduction size. I don't know, but somehow clinically they are similar. Okay, adverse effects very quickly: impotence, abnormal ejaculation, reduced ejaculative volume, gynecomastia. All when you reduce the androgens, you will have all these symptoms: depression, anxiety, and then there's one more thing about concern for the prostatic cancer. Some of the trials have shown, there are 2 trials which showed reduced risk of prostate cancer compared with placebo. But at the same time, there is a possible increased risk of high-grade prostate cancer. So you might discover more high-grade prostate in these patients. But overall survival, there was no survival benefit of giving this drug for the prevention of prostate cancer. There was no survival benefit. So there's just this controversy on this thing. So it's better if you're starting somebody in this drug for BPH, just do a little bit more workup to see that there is no cancer sitting in the prostate. And because also it reduces the PSA levels by 50%. So again, if you're using PSA levels just to see if there's a prostate cancer not in your surveillance, like so again that might also like bias you. So either you should have a baseline PSA before starting the drug, or while somebody is on the drug, then probably you need to multiply it by 2. So that's another issue. Okay. Now combination therapy of alpha-1 adrenergic antagonists and 5-alpha reductase inhibitors. Obviously, alpha-1 blockers, as we just discussed, they will relax the smooth muscles of the bladder, neck, and prostate, so they will improve the symptoms, flow rate, and reduce the obstruction. They will relieve the obstruction. While 5-alpha reductase inhibitors, they will reduce the action of androgens on the prostate, so they will shrink the prostate and improve the symptoms and relieve the obstruction. So you want to combine them to both of them. Sometimes if you don't have enough relief with one, then you can combine, and this will be rational. This is just one study which showed something similar. So these are different symptoms. Again, just keep in mind that here there's a term you use like this prevent symptomatic progression. So they are just talking about symptomatic progression, huh?
Down, yeah.
They are not talking about disease progression. This is just the symptomatic relief. So symptomatic relief is in both, huh? But like with the alpha blockers, the onset of symptom relief is much quicker. 5-alpha inhibitors will take much longer for this relief. While the reduction in the prostatic volume and need for reduced need for surgery happens with 5-alpha reductase inhibitors, not with 5-alpha, also not with the alpha blockers. And so you can use a combination to achieve all these objectives. Okay. Now phosphodiesterase 5 inhibitors, PD5 inhibitors. Are you aware of any PD5 inhibitor? Sildenafil with Viagra, huh? And if we had this interesting lecture on male sexual dysfunction, we would have talked about that, huh? But there's another one, tadalafil, and this one is approved for use in BPH as well, because it also relaxes smooth muscles in the prostate and the bladder, so it helps with the obstructive symptoms. So there is some role of this as well, especially if somebody who has erectile dysfunction and BPH symptoms, you can use this drug as well, so it will help with both, huh? See, everyone remembered Viagra, but what about, did you do pulmonary hypertension?
Yes.
Yes.
So is there any role of PD5 inhibitors?
Yes.
So both sildenafil and tadalafil can be used over there as well, huh? Because again, relaxes smooth muscle cells in the vasculature. So they are present in corpus cavernosum, pulmonary vasculature, prostate, urinary bladder. So tadalafil is approved by FDA for the treatment of management of symptoms of BPH, and it relaxes the smooth muscles, and hence it relieves the obstruction. It also is used in erectile dysfunction and pulmonary arterial hypertension. Adverse effects: headache, indigestion, flushing, nasal congestion, and priapism rarely. You have to be very careful while using these nitrates, because it can induce severe hypotension, and for the same reason you want to avoid it in severe cardiovascular disease. And you have to be cautious if you're using alpha blockers, which also act on vasculature. Huh? If you're using trazocin, doxorubicin, which are acting on the vasculature, then you want to be careful while using this. Okay. Then there's some role of, if somebody is having more irritative symptoms, like there's overactive bladder, like there's urgency, urgent incontinence, frequency is more, then you can use another category of there's another category of drugs which is like beta-3 adrenergic agonists, and then anticholinergics. These two categories can be used somebody who is overactive bladder. Obviously, lifestyle modifications are important. So beta-3 adrenergic agonists, again they stimulate the retrosal beta-3 adrenergic receptors to promote relaxation. So the agonist beta-3 receptors, they will relax the bladder muscles, so it will help with the overactive bladder. Similarly, the same thing with the anticholinergics or antimuscarinics. I haven't put any drug names, so you don't need to worry about that. Okay. And they also relieve the irritative symptoms, but you have to avoid this drug in somebody who has high post-void residual volume, because as they are relaxing the bladder, and if they have already so much obstruction that there is a high post-void residual volume, then they can go into acute urinary retention. So one of the side effects of these drugs, especially the cholinergics, mainly for the cholinergics, anticholinergics, there's a risk of acute urinary retention. So you don't want to use in somebody who has a post-void residual volume of more than 300 ml. You don't want to use it. It's not recommended for them. So somebody who has low post-void residual volume and symptoms of overactive bladder with BPH, then probably there's a role of this category. But again, your main step treatment is
Symptomatic.
which drugs?
Alpha 1A.
Alpha 1A.
I will.
Alpha 1A. The first line for the symptom relief you use in BPH is alpha 1 blockers, and then you will prefer alpha 1A blockers like those tamsulosin, nasredosin, like those that effuzosin, which are more uroselective. But somebody who has hypertension as well, you can also use
Sometimes not sometimes.
non-selective, which are
Doxycycline.
doxycycline. Yeah. But like alpha 1 blockers are your first line choice, and then you can add
5-alpha reductase inhibitors.
5-alpha reductase inhibitors, which are the only drugs which will
Reduce progression.
Those shrink.
will shrink the prostate, will reduce the disease progression, will reduce the need for surgery, and also will relieve obstructions or relieve the symptoms, but it will take much longer time. And then your third category, which is PD5 inhibitors, and then you have this. Okay. Now let's talk about the prostate cancer very quickly. You've done prostate cancer,
Yes.
and you have a clinician's lecture as well, So what are the different treatment options? Surgery, observing,
Radiation.
radiation,
Chemotherapy.
Who said chemotherapy? Okay. So again,
You can, I think he also mentioned, you give estrogen, like anti-androgen. Can help.
in these patients,
That's what you mentioned. Just ask, is it correct or?
estrogen probably not mainstay of treatment. There's a possibility of using estrogens, but not the mainstay of treatment. Mainstay of treatment, like again, it depends. I don't want you to get confused among different. Like it's very complicated when it comes to. But you just remember when it's localized disease, localized in the prostate, and a low risk. So first thing you do, watchful waiting or active surveillance. These are two options, like watchful waiting and active surveillance. There's a little bit difference. Active surveillance involves biopsying and MRI as well. Then if a localized disease you want to do intervention, you go with radiotherapy as well. So radiotherapy, again, there are different types. It's not my focus today, but like you have external beam radiation therapy, you have brachytherapy, and then there are other radiation therapies as well. And there are many other new therapies coming in, just in radiotherapy. But at least you should know about external beam radiotherapy and brachytherapy. Again, not for my lecture, I'm just saying like it's good to know those things. And then as our friends said, surgery. So we have surgery. These are our main treatment options. When there is locally advanced disease, or very high risk disease, or metastatic disease, then there is a role of pharmacotherapy. And again, the mainstay of pharmacotherapy is androgen deprivation. Okay, so you want to deprive them of androgens, and we have like three ways. The primary androgen deprivation is like androgen deprivation therapy, which can be achieved surgically by just cutting of the testes, bilateral arthrectomy, because 90 to 95% of the androgens in males are coming from testes. Or you can do a medical castration by using GnRH agonists or antagonists. Both will achieve the same. And then as an adjunct, you can use androgen synthesis inhibitors and androgen receptor antagonists. So this is all under androgen deprivation. And then if it's a metastatic disseminated disease, then there is probably some role of chemotherapy as well. And there's a role of immunotherapy as well. But we will not talk about immunotherapy. Hopefully next year, if it's a 1 hour lecture, then probably we can do an immunotherapy as well. So we'll just talk about androgen deprivation and one slide. So for each category, I have put only one drug. So androgen deprivation therapy, let's just, so it's aimed at decreasing the testosterone production by the testes. That's the purpose. So we can achieve by medical castration, surgical castration, as we just talked about. The purpose is with the medical castration, we reduce the pituitary stimulation androgen production by testes to a castration level, which we define as serum testosterone level less than 50 nanograms per year.
15?
50,
Okay.
less than 50 nanograms per year. That's defined. Like if it's less than that, that's our like medical castration. That's what we want to achieve. And indications: clinically localized high risk prostate cancer as an adjunct to radiation therapy. Again, the main treatment is radiation therapy when it's localized. If it's locally advanced and very high risk prostate cancer or a metastatic disease. Major role comes in metastatic disease. Okay. As a group of androgen deprivation therapy, as a group, side effects would be we are reducing androgens completely. So obviously the lean body mass, the muscle mass will go down and the body fat will increase. There will be sexual dysfunction, loss of libido, ejaculatory problems, all those things with erectile dysfunction. And obviously there will be reduction in bone mineral density, so that will lead to more osteoporosis. So these patients are already aged, and then because of this thing there will be more osteoporosis, so increased risk of fractures. And then these patients might have bony metastasis as well. So their bone health is important. And obviously vasomotor instability, hot flashes, and then there are gynecomastia and other effects of low androgens. Okay. So let's talk about the first drug, GnRH agonist. So you know what does GnRH do? The GnRH will stimulate the pituitary gonadotrophic cells, gonadotrophs, to produce LH and FSH. LH will stimulate the Leydig cells to produce testosterone, and it will stimulate sertoli cells to produce FSH stimulates sertoli cells to produce spermatogenesis, and also there is a role of testosterone. So you want to reduce the production of LH from the pituitary. So normally GnRH is stimulating the LH production in a pulsatile fashion. So GnRH is coming out in, you must have done in physiology, in a pulsatile fashion. So if you give it continuously, GnRH, it will reduce the LH production. So it will achieve the same thing as an antagonist. So otherwise, you would think why you want to use agonist, but you have to use it continuously. If you want to increase LH, you use the same agonist but in the pulsatile fashion. So I've just put one drug, leprolide. There are many other drugs, but like with each I just put one, leprolide. So it's an analog of GnRH, and when you give it continuous or non-pulsatile format, so it will lead to excessive stimulation of the pituitary, and which will eventually lead to reduction in GnRH receptors and decrease LH-FSH secretion, low testosterone. But in the beginning, first few weeks, it will increase the LH production and will increase the androgen production. So somebody who has disseminated disease or obstructive symptoms somewhere, so it can make the disease worse as well in the first few weeks because of this flare phenomenon, surge in testosterone in the beginning. So to prevent that, you can use it with some anti-androgen like flutamide for the first few weeks, and when the levels come down, then you probably can stop anti-androgens. Okay, but later on it's same as GnRH antagonists, same effect. Indications: is used as an androgen deprivation therapy in prostate cancer alone or in combination with anti-androgens. Other indications you don't need to worry about them, forget about them. Okay, side effects same as ADT like we described previously. Antagonist, GnRH antagonist, bigger LX, one drug. Okay, it's a synthetic GnRH antagonist. It will block GnRH receptors in the pituitary, so it will reduce the LH-FSH secretion and will reduce testosterone. Okay, but as it is doing directly, the blockage and inhibition is direct, so there's no initial stimulation of this axis, so there's no testosterone surge, no flare phenomena with GnRH antagonist. And that's why we achieve the medical castration sooner with GnRH antagonist compared to GnRH agonist. Okay. But later on they are similar. But it's just the only initially we achieve this effect soon. Indication same as as androgen deprivation therapy in prostate cancer. Now, which stage of prostate cancer you don't need to worry about. It's from my perspective. Side effects besides ADT, like we already described, there is hepatotoxicity and weight gain. Androgen synthesis inhibitor, abiraterone. Again, it is used in advanced disease and in metastatic disease as an adjunct to an androgen deprivation therapy. So we give androgen deprivation therapy like against antagonist, and as an adjunct to that we use this one. Now this inhibits 17-alpha-hydroxylase and 17-20 lyase as well. So it inhibits the androgen synthesis in the adrenal glands, testes, and prostate tumor. Because we know there's 5 to 10% androgen coming from other tissues like adrenal cortex as well. So you want to inhibit it everywhere. But the and obviously the indication is as an adjunct to ADT. Okay? And the problem is because it's inhibiting 17-alpha-hydroxylase and 17-20 lyase, so it will also reduce, besides androgens, it will also reduce glucocorticoids, and it will increase the mineralocorticoids. Because it will reduce the glucocorticoids, they can have adrenal insufficiency crisis. So you have to use it with prednisone. So you have to give exogenous prednisone. Side effects, because there's an increased production of mineralocorticoids, so there may be hypertension, hypokalemia, cardiac arrhythmias, and because there's inhibition of glucocorticoid production, so there will be adrenal insufficiency. So you have to use it with prednisone. Other side effects, because when you're using abiraterone with prednisone, they are already on the androgen deprivation therapy. So androgens are down, and you are giving prednisone as well. So there will be more bone fragility, more osteoporosis, more risk of fractures. Okay, and besides the hypertriglyceridemia, hyperglycemia, and elevation ALT, ST, these things. Androgen receptor antagonist. Just remember, it's one drug, apalutamide. But historically, there was first generation drugs which are now used for prevention flare, like that included flutamide, but you don't need to remember their names, okay? The name that you need to remember, I put it on the top, okay? And then there is second generation. So apalutamide is a second generation, which we use now. Previously, they used to use flutamide more, so you might hear flutamide from other people. And this apalutamide is an non-steroidal anti-androgen. It competitively inhibits androgen binding to androgen receptors. It functions as androgen receptor block. Okay? Again, as an adjunct to ADT in prostate cancer. That's where we use, and these are side effects you don't need to worry. When it's disseminated disease, metastasized to distant places, so then there may be some role of chemotherapy. And the first choice in chemotherapy is docetaxel. You remember paclitaxel?
Yes.
You did in POD, so it's same category. So it's semisynthetic taxane chemotherapeutic agent like paclitaxel. So it hyperstabilizes the polymerized microtubules. So remember, there is in M phase there is this mitotic spindle formation. So there's a polymerization of microtubules, and then there's a depolymerization of microtubules. So there's a category of drugs which inhibits the polymerization. Then there's a category of drugs which inhibits the depolymerization. So taxanes inhibit the depolymerization. So this drug inhibits the depolymerization of macrotubules. And so it it inhibits the mitotic spindle breakdown. So there's a arrest of the cell in the M phase. Okay. So it arrests the cell cycle, and so obviously cell will eventually go in apoptosis. So it's a chemotherapy agent. It's indicated as an adjunct to ADT in metastatic prostate cancer, like disseminated disease. There are other indications, you don't need to remember those. Side effects: myelosuppression, alopecia, neuropathy. Bone health, obviously we just discussed, because they are at a very high risk of osteoporosis and bone fractures. So you have to give them prophylaxis to prevent this osteoporosis and fractures. Any questions?
For you said the finasteride is more powerful. Could you describe for what reason?
No, I did not say more powerful. As dutasteride is more potent are more effective in reducing the dihydrotestosterone because it acts on both isoenzyme type 1 and type 2, dutasteride. Finasteride acts only on type 2. So dutasteride is more efficacious in reducing the levels of dihydrotestosterone in patients. It has been shown in clinical trials as well. But clinically, when you're using, both are equally effective. Like when it comes to symptom response, you give somebody at the end of 6 months, you ask them how much obstruction are they feeling, like there are different rating scales. So when you assess them, both have equal response. So clinically, response-wise, we have similar results, but hormonal-wise, dutasteride, because it's blocking both isoenzymes, it is able to reduce dihydrotestosterone at a more higher, like it reduces much more. Like there was 90% reduction compared to 70% reduction when you compare dutasteride with finasteride. So more reduction in DHT with dutasteride.
Thanks. And then for alpha-zocin, you said it's in vivo, it works, but in vitro?
No, alpha-zocin we categorize as alpha-1A selective or uroselective blocker, okay, with tamsulosin and celidosin. But if you are doing an in vitro study, it's not selective. Like it's not only like it acts on other alpha-1 receptor subtypes as well. But clinically, it doesn't produce hypertension. It has no effect on blood pressure. So you will not give it to somebody who has hypertension. So like if you, that will be not your indication. It's only acting only on the renal, the bladder, neck, and the prostate. So it is effective in relieving the obstructive symptoms of BPH. So that's why we keep it with the category of uroselective or alpha-1A selective blockers. Okay.
What is the first slide here?
In BPH?
Yes.
Yeah, so again your focus should be BPH. Like for the cancer, just like as you know, the main management is non-pharmacotherapy and pharmacotherapy, just androgen deprivation, and there are only like 4 or 5 drugs named, so you just remember those names. Otherwise, your more focus should be on BPH part, and BPH, again first line, as I said, for the symptomatic relief, it's alpha-1 blocker.
Selective or non-selective?
Yeah, you try to go with selective, like the alpha-1A selective blockers. That should be your first choice for the symptomatic relief. But if you have somebody who has hypertension as well, and if you want to control his hypertension with the alpha blocker, then you will go with the non-selective alpha-1 blocker, like trazocin or trazocin. So if you want to achieve both ends, blood pressure as well as BP symptoms, then you will go with both. But only one, like only for BPH, then you will go with the alpha-1A selective. And then you have 5. What is the other category?
5 alpha reductase.
5 for reductase, and which is the only category which will? Yeah, it will shrink the volume, it will reduce the obstruction, it is the only thing which will prevent the disease progression and it will reduce the need for surgery. Yeah, so it is the one which alters the natural history of the disease. Huh? And then you can use combination as well. We don't use it always because obviously it has the 5 for reductase had other side effects. So elderly male already things may not be working well, and so they don't want to use these 5 for reductase blockers. So they will have more erectile dysfunction. So again, when it comes to management of BPH as well as prostate cancer, it is always about shared decision making. There are different options available. You have to discuss with the patient and their needs, their other comorbidities, their values, and then you decide accordingly, especially when it comes to prostate cancer. So then you choose the appropriate. So again, usually the first line is alpha-1 blocker. And obviously you will go with alpha-1A selective, and then if there's hypertension, then you will go with non-selective. Okay? And then your PDE5 inhibitor as well, which you can add if there's a patient with BPH as well as erectile dysfunction, then you might want to add it. It will help both. Okay? And if somebody who has overactive bladder, then probably you might want to add. Yeah, but then you need a post-void residual volume, and you want to make sure that's not very high. Otherwise, they will go in urinary retention. Okay?
Thank you.
Thank you.
Best of luck for your exam. Thank you.